So I've been asked to answer the question of, is PSA the best that we can do? And I work in Cambridge with David Neal, as he's already mentioned, on new biomarkers for detecting prostate cancer. And really there are 4 key questions that we need to answer with biomarkers. The first is the risk of developing prostate cancer. I'm not going to talk too much about that because Chi is going to speak after me, and hopefully he's going to give us a bit more information about the risk of developing prostate cancer. The second is diagnosing the disease, and it's not just diagnosing all disease. I know later on we've got talks about whether Gleason 6 is actually cancer, so we really want to be just to diagnosing the clinically significant disease, so the aggressive disease. And I think there's been a lot of work in the last few months and the last year actually on that area. Difficult to diagnose disease. So those men with raised PSA negative biopsy, what's the best we can do for those? Do we have markers that will actually be able to identify which of those men have got prostate cancer and which actually don't have anything at all and don't need to worry? And also predicting response to treatment. So who's going to relapse? Who should we be offering surgery to? Who should we be offering chemotherapy or radiotherapy to? Who should we be offering the new drugs such as abiraterone to? We really don't know fully who's going to respond best to each treatments. And if we had markers to predict those responses, it would obviously make your jobs a lot easier. So at the moment we have the PSA test. It's the mainstay of treatment. It's what everybody's using. And the main question is, why do we need to improve it? I'm sure I don't need to tell this audience that it's not particularly good. This is 100 men. If we tested this 100 men and gave them a PSA test, 21 of them would have a raised PSA, which would require further investigation. Of those, only 5 would actually have prostate cancer. And of that 5, only about 2.5 or 2 to 2.5 of those men would actually have prostate cancer that would actually require any further treatment and that would be aggressive enough and will kill them. So actually, those are pretty poor stats. And so we do need to improve it and find other ways to diagnose prostate cancer. But which biomarkers are the most promising? It's a bit like looking for a needle in a haystack, isn't it? I did a PubMed search just this morning and searched for a prostate biomarker, and there were only over 25,000 hits, and I did the same search last week and there were 100 less hits. That's how fast people are publishing these prostate biomarkers. But actually, we're still just using PSA in the clinic. We're not using all these other markers, so something seems to be going a little bit wrong here. So what is going wrong? A lot of the studies are very small cohorts, and they're not validated in an additional independent cohort, which means that they're never seen as being robust enough and never taken forward. And also, biomarkers to answer which question. We flout this idea of biomarkers around, people say it all the time, but actually, which question are we trying to answer with these biomarkers? Is it an early diagnosis question? Is it an aggressive cancer question? Is it a screening question? There's so many different questions we need to answer. And are the cohorts that are being tested actually appropriate to answer the questions that we're trying to answer? So we need to make sure these things all match up. And so hopefully I'm going to be able to take you through some of the things in each of the different areas, in each of the different questions now, the things that are most promising in all of those different areas. So the one that you probably have heard of that has also been in the press quite recently is the PCA3 test. And I suppose after PSA, this is the test that is most frequently used. It's urine-based and it has to be post-DRE, which means it's probably unsuitable for a screening test to be used on our population. But it's expensive, about £300 for the test. And theoretically, well, there's several strands of evidence now suggesting it's not as effective at detecting higher grade cancers. So anything that's got a primary Gleason 4, the idea is that the cancer is so tightly packed that actually the small non-coding RNA that is PCA3 that we detect actually can't get out into the urine, which means that we can't detect it. So for those aggressive cancers, for those cancers that we're more interested in detecting, actually we can't detect them using the PCA3 test as well. So that kind of questions slightly its utility. However, it has found some usefulness in men with raised PSA and negative biopsy, and maybe that's the place where it could be used. Although, on saying that now, we've got imaging. I think we're going to hear from Claire Allen later on today. Imaging has come on so much in the last few years, and also template biopsies are more widely used now, and actually putting those two things together, perhaps they're more useful for those men with the raised PSA negative biopsy than using a PCA3 test. So more recently, in the last few weeks, there's been a publication and a large press release about combining PCA3 with the temporous ERG fusion that David mentioned in his talk. It's called the MIPS test. And there's a suggestion that actually this will improve the PCA3 test because you're combining this genetic marker for prostate cancer with the PCA3 test. And I think actually putting those things together actually probably does have utility, because I think having a single marker for prostate cancer to answer any of those individual questions is something that's not going to happen. We're going to have to be combining different modalities and different markers in order to answer the questions that we're interested in. Another protein that you may have heard about and that we've worked on a lot in Cambridge is Microseminoprotein-beta. So this is MSMB. It's one of the most abundant protein that's found in serum after prostatic acid phosphatase. And we know that it inhibits growth by regulating apoptosis. There is a small change in the DNA in the promoter of the MSMB gene. It's called a SNP, and this is what she is going to talk about after me. And we know this is linked to the risk of developing prostate cancer. So patients that have got the low risk form of the SNP, they produce lots and lots of MSMB. And the theory is that, or what we know now to be true, is that they have lots of MSMB and therefore it regulates apoptosis more and keeps the prostate more regulated. And this makes sense. Patients who are at high risk of developing prostate cancer have much lower levels of MSMB, and therefore there's less apoptosis. Prostate grows in a more deregulated manner, and they're more likely to go on and develop cancer. So we've published some work on this over the last couple of years, but this is just to give you an idea of what it looks like. So this is a radical prostatectomy from a PT3 patient with a PSA of 10.8, and this is the kind of marker that, as a scientist, we need to be taking forward from the science into the clinic. This is not something that's a shades of grey. This is a black and white response. So down here, we have all of the benign regions, and you can see they stain really strongly because MSMB is lost when you get tumorigenesis. Up here is the region of tumour, and you can see here, it's a black and white. It's like somebody switched the light on and off, and this is what we need. It's a black and white response. And here is a region of PIN, and you can see here you get the characteristic changes within a gland, which are reminiscent of PIN, which we see with PIN. And so this is what we see with MSMB, and in a little bit more detail, this is looking at in a quite a large number of patients in tissue. You can see that actually we lose expression very early on in PIN, and then it continues to be lost with increasing grease and grade. We've also developed assays to detect it in blood and in urine, and we get very good areas under the curve, particularly for our detection in urine, which obviously is very amenable to the patients. Another protein that's actually starting to look increasingly interesting is engrailed 2. So on first look, it seems a little bit strange. This is a homeobox transcription factor. It's found in the nucleus. So, you know, what's it doing? It's linked with development, but it's never really been linked with tumorigenesis before. In 2011, a group out of Surrey published a paper in Clinical Cancer Research showing that in patients with positive biopsy-confirmed prostate cancer, there were high levels of engrailed-2, and this wasn't found in biopsy-negative or patients without prostate cancer. And this was interesting, but as you can see, the population, the N numbers were quite low, although it was validated in a second cohort, and we did some of that work in Cambridge. More recently, this study's been taken on even further, and they've tested, in collaboration with Roseille's group, they've looked at BRCA1 and 2 carriers, and they've actually got some quite interesting sensitivity and specificity data, and shown that actually it is rather good, it is got potential to be a good biomarker for diagnosis in prostate cancer. But there was no link to the BRCA1 or BRCA2 genetic factors. They've also very recently published that it might also be useful in bladder cancer diagnosis. So although on first glance it looks like an unlikely biomarker, actually it looks like it's turning out to be really very useful. As was mentioned at the end of the last talk, you may have seen this last week in the press, in the BBC, the cell cycle protein score, the Prolaris test by Myriad Genetics. This is combining 31 cell cycle genes with 15 housekeeper genes. Patients with the higher CCP score are more likely to die from cancer, so these patients here have got much higher CCP scores, and the patients with the lower scores actually do much better. This is really good, and actually this is being marketed as a test for aggressive prostate cancer, not just for prostate cancer diagnosis per se, but it still requires a biopsy. And although maybe for the next 5 or 10 years we may still be doing biopsies, hopefully after that we may start doing something where we can actually rely on a blood test or maybe work on urinary sediment. So maybe this can be converted into a blood test, and this is the same for all of the gene signatures. I think if we can convert these into something that we can measure in urinary sediment or in a blood test, then this is a way to take them forward in a less invasive way, which is more accessible to the patients. With this method as well, we're not sure whether the time and the fixation method will influence the result. I haven't been able to find any evidence of that. And also how much cellularity there needs to be. And so I think for all of these studies, there needs to be a much bigger study going forward to see how useful it would be and how many patients we have to exclude because the pathology isn't good enough to be going forward into these tests. So we've talked about aggressive cancer and we've talked about diagnosing all cancers. One area that's started to get really quite exciting, and there's been some really nice publications on quite recently, is using circulating RNA signatures. And there were back-to-back publications in New England Journal of Medicine in November last year by Johan de Bono's group and by a group from the States, Bio. And they did both did studies, prospective studies, looking for a gene signature to predict castration-resistant prostate cancer that could be detected in RNA that's circulating around the body. They both found signatures. However, there was absolutely no overlap between those two signatures. And they did do it in a slightly different way. So Johan's group, they took the RNA from the patient, they amplified the RNA and they ran it on normal expression arrays. The O group actually did a literature search and did targeted arrays. So maybe it's not a huge surprise that there's no overlap, but it's still a concern. If we want a robust test going forward that can be used in the clinic, then this potentially isn't the way to be doing it. More recently, Hans Lilja published a paper looking at the kallikreins in PAX gene and showed that actually, although it was reasonably good, if you combined it with circulating tumour cells, it was even better, and it was actually a very robust way of detecting castration-resistant disease and prostate cancer. So I think this, as a method, actually has potentially great use and is potentially very interesting for patients because it doesn't require sticking needles into patients, but it definitely needs more standardisation of the method and how we apply that method before a more robust signature that can be applied to all patients can be identified. And I do have a question about whether actually identifying patients who are going to go on and have castration-resistant disease, at the moment, do we have anything that we can offer those patients other than surgery that actually might prevent them getting to that point in their treatment? So there's a question mark over that. So this is probably the area in terms of predicting response to treatment where I think we've probably got the least number of markers. And this is probably because in terms of trials, at the moment, we're probably quite poor at identifying biomarkers in with actually giving the different treatments. And we're just not very good at it at the moment, and it's an area where we need to improve. However, there's one marker which at the moment is a standout marker, which seems to have a lot of promise, and this is a protein called GDF15 or MYC1. Now, interestingly, there is a SNP, this small change in DNA, also found in GDF15 and MYC1 that seems to predict for aggressive disease, but it also seems to be able to predict response to treatment, so response to docetaxel. So in this paper, they showed that the greater the percentage decrease in MYC1 following treatment, the more likely a patient was to have a response to docetaxel. So I think this is a really interesting finding. It's one, again, that needs to be taken forward. So just to sum up, is PSA the best we can do? So I think PSA is still really, really important. And I think the key message is let's not throw the baby out with the bathwater here. I think PSA is always going to be important, and I don't think we're ever going to get rid of it. But what we need to be doing is combining things with PSA. Many of you will have heard about using the 4-panel kallikreins, which is total free PSA, and PSA human kallikrein peptidase 2, related peptidase 2, and using those things together can predict whether patients can be used for screening to detect whether patients should be given biopsies. And so actually taking PSA further and doing different things with PSA may be one way of doing it. Combining PSA with other markers to answer the specific questions. So we may well have a panel of markers which is PSA, PCA3, TMPRSS2 ERG, and some other new markers, and maybe NGREL2 for diagnosis. And then we might want to combine PSA with the CCP score and some other markers for aggressive disease. And so combining them in all of these different ways will allow us to answer the questions, but we must get away from the idea that it will be a single marker will actually do everything. We also need to think about combining them with DNA signatures, RNA signatures, SNP profiling in order to get the answers that we want. And so the key question for us as scientists working with you as clinicians is, how do we combine these and how do we get the right cohorts to answer these questions? So finally, I'd just like to say, any questions?
Thank you, Hayley. That's superb. Okay, it's open to the floor. Are there any questions at all? Tim O'Brien. Good job.
Hey, I enjoyed your talk. Tim O'Brien. One of the problems in this disease is that because the outcomes are quite a long way down the line, you don't get the answers very quickly, and then there's new information comes around. And it's not just a problem for biomarkers in prostate cancer, it's a problem for all things in prostate cancer. That by the time you get some sort of an answer, everyone goes, well, it's no longer a relevant question you're asking because we've got more information. How does one address that as a scientist interested in markers?
So the key thing for us is getting the right cohorts, and I think actually PROTECT is going to be a fantastic cohort for answering those questions. So you're right. I mean, at the moment we have some great cohorts for diagnosis, for early diagnosis, but having that follow-up so that we can say, is it good for aggression, is it good for other things? You know, we have a few cohorts that are good for that, and we collaborate with other groups as well to get those independent cohorts, but perhaps we all need to be working together to create very large cohorts that come from different centres that will get rid of any variation, centre-to-centre variation, and will allow us to take these markers forward to get something that we can use in clinic. Because at the moment, we have a lot of things, like you say, that fall by the wayside, a lot of potential markers that never quite make it.
Which may have been very good.
Absolutely. If we study them properly. But I think we maybe need to, almost as a group, say, we are going to put together a collective cohort for early diagnosis. We are going to put together a collective cohort for aggression. That's not just a few hundred samples, it's thousands of samples. Because that's got the power then to go forward to become something clinically useful. But at the moment, if you're pootling about with 10, 20, or even a few hundred samples, that's just not good enough.
Sorry.
That was a great overview. My question is partly rhetorical, which is that as clinicians, we look at this kind of data, we see ROC curves that look better and better, and sensitivity and specificity figures, but we have to take that to the clinic. And my question is really, what is the right metric in all of that statistical analysis for being able to say this marker is the one that's actually going to work for us? I think, in my opinion, negative predictive value, at least for predicting non-progression, is a very powerful one, but often is absent in the reports of these kind of biomarkers. So, and then my other question was about the OncoDX assay, which is one of the few assays that's actually been approved for use in the US. I don't think you mentioned that. I just wondered if you can comment. I mean, it's available now. What do you think its role is?
I think the role of OncoDX, potentially very interesting, but again, we need to be doing more patients, more cohorts. I think a lot of these markers, all these marker signatures are actually being made available before we've done big enough studies to have any real confidence. And that's because, let's be honest, there's potential to make financial gain here. But actually, that might not be for the best use of the patient. So I think for all of these markers, we need to go forward. In terms of the metric, I think we almost need to have a minimum requirement for biomarkers and say we need sensitivity, specificity, positive and negative predictive values in all publications. And then going forward, I think it's probably going to be some kind of nomogram type of way going forward that clinicians can use, or some kind of program with a nice interface that can be used, because it's going to be combining data, and that's not going to necessarily be something that a clinician can do, going looking at this figure and this figure and this figure, combining them together in my head. I know roughly what the risk is, and therefore I can suggest this to a patient. I think it's going to be more involved than that.
Yeah. Just whilst we're getting there, one of the things we've been involved with Ian too, as you kindly mentioned, and the issue of a biobank is such a shame we don't. I mean, Bowel oncology, we're seeing so many patients the whole time, and if we were storing urine, blood, tissue, and we could answer so many of these questions in 1 year, we would have, or 2 years, thousands of samples. We could have done that so long ago. We're constantly going to say, well, what happened to these people then, and what was it showing? And yet, every time a new lab comes up with a new biomarker, you start, well, where do we find the samples, and how do we know whether they're going to be a response to radiotherapy and how have you got on with trying to assess that and trying to develop that, which just takes time to do?
I mean, I'm lucky enough to work with David Neal, so he has some fantastic collections. But also we collaborate very closely with Henrik Gronberg, with Freddie Hamdy over in Oxford. And so actually we have access to some fantastic collections, but I'm just very lucky. Not everybody does that. And there are some great biomarkers out there that aren't being taken forward because they don't have access to the collections we do. So I think the idea of collectively coming up with cohorts to answer individual questions is one that we should, we should seriously think about, because it will allow these markers to really be taken forward, and I think that's really important.
Mark Laniardo, I use I'm over here. I use the PCA3 test, and I've tried the four-panel
Yes.
prostate check as well. And one of the issues I have is that when I try and interpret the results, the probabilities given for the diagnosis of any disease or high-risk disease is usually based on transrectal biopsies. Now, I've moved to doing mostly transperineal biopsies, and so I'm finding it difficult on how to advise patients about what the chance of developing cancer on a biopsy will be. So how do you feel the use of transperineal biopsies as a reference standard will influence the interpretation of all these tests?
I have to confess, I'm not a clinician. And so I might have to defer to my learned colleague, or to David, perhaps, to answer that question.
Well, I think template biopsies are going to be great for getting hold of men who are truly negative, as far as you can possibly tell. So I don't know where Mark is, actually. But, so I think that's going to be important. And, yeah, I think those data are going to come out, aren't they? But you know that the template biopsies are going to be picking up 20 or 30% more cancers, and you're going to pick up another 10% high-grade disease or something like that.
Thank you, David.
Yeah, that's important.
I mean, we're using the template biopsy men as our true benign cohorts for our work, because if we don't take samples from men unless they come to clinic. First problem. And so they tend to have a raised PSA, and even if they've got a negative biopsy, we know that around 30% of those men are going to have prostate cancer. So we're using our template biopsy men as our true benigns, as close as we can get them.
Okay, Tim O'Brien again, please.
Who said you don't get questions in the basic science session?
This isn't a comment about basic science, but it is a comment about scaling up, and clearly it's something I'm interested in. I think if we look at what's happened in renal cancer with nephrectomy, because we've scaled up this year. There've never been more than 2,000 nephrectomies registered. This year there've been 6,000 registered. Wow. We've never had an abstract at a meeting about registration of British cases. We've got 11 abstracts going in on nephrectomy for international meetings next year, and that shows the power of scaling up. And I think it's going to come in prostate cancer next year, mandatory registration of radical prostatectomy. We scale up the registration. And once we've scaled up the registration, I think we'll start to think more as the totality of the country's cases. And then I think we'll be able to scale up the science. I think the scaling up of the registration that's gone on is already making a difference to how we're viewing our country's work. And then I think we can start to think about, scaling up the science that relates to it. So I think quite rapid progress on that. But I think in prostate cancer, next year it's that mandatory registration, which has been happening this year with nephrectomy.
I mean, I think that's going to be, if that happens and we do get that scaling up in prostate cancer and we can get a feel for an overview. It's happening. And we can get an overview of actually what is happening and what kind of patients are being treated countrywide, not just locally. You know, I get a very local picture, although we collaborate with people from other centres. You know, we're not getting patients from, you know, the north, socially deprived areas. You know, we're from working in a very affluent area. And even just between working in Cambridge and getting samples from London, we see differences in terms of the amount of prostate cancer, the cancer volume, the multifocality of the cancers. And that's just working between Cambridge and London. We see much more aggressive, much more advanced disease, much more multifocal disease, larger volume disease in Cambridge because there's less PSA testing in Cambridge. So it would be really interesting to see actually across the whole country what kind of patients are being operated on.
Okay, fine. Well, we're keeping to time, so